one must understand it is equally important to keep in mind that the rate of rise of serum potassium is perhaps equally or more important than an absolute number of serum potassium. Person with acute kidney injury whose potassium suddenly jumps from 4 to 5.5 in less than 48 hours can literally land up in cardiac arrhythmias and even cardiac arrest with that rapid rise of potassium. Acute hyperkalemia is a medical emergency for three very, very important reasons. Number one, it is invariably, almost always asymptomatic. See, during the acute hyperkalemia treatment, three things are to be monitored very, very effectively. Number one, the acid-base balance. That you have to make sure that the patient is not acidotic at the outset and not becoming acidotic during your course of treatment of hyperkalemia. Because if the patient becomes acidotic, your hyperkalemia will return back again. So one simple piece of advice is hyperkalemia is far more rampant than what you clinically think. Number two, acute hyperkalemia is a life-threatening medical emergency. Please treat it as it is. Number three, when treating the hyperkalemia, look at the ECG all the time. A hyperkalemia with ECG changes is far more dangerous than hyperkalemia without ECG changes. Rate of rise of serum potassium is equally important as an isolated potassium value. And when you are treating hyperkalemia, monitor sugars, monitor ECG, and in select individuals, of course, you have to monitor their acid-base balance.
Hello and welcome to Potassium Matters, Decoding Hyperkalemia, an initiative by Voice of Healthcare supported by AstraZeneca. This is a clinically focused, insight-driven audio series where we break down one of the most critical yet often overlooked electrolyte imbalances in everyday practice. Let me start with a simple question for you. How often do you look at a potassium value and move on? Just another number in a lab report, right? But what if that number is actually one of the most powerful indicators of cardiac risk, clinical instability, and patient outcomes? Because potassium isn't just a routine parameter, it's a dynamic signal of what's really happening inside the body. In this series, we take you step by step through the fundamental of potassium physiology, the clinical spectrum of hyperkalemia, and most importantly, what to do when it matters the most, in both acute and long-term settings. Whether you are a clinician managing complex comorbid patients or someone curious about the science behind electrolyte balance, this podcast is designed to give you clear, practical, and actionable insight you can actually use. In today's episode, we begin at the foundation. What does potassium really do, and what happens when it goes wrong? We'll explore the clinical importance of potassium balance, especially in acute care scenarios, where even small shifts can have serious cardiac consequences. And to guide us through this, we have a distinguished expert with us today. Joining us is Dr. 𝗪𝗂𝗃𝗀𝗃𝗀𝗃, Section Head Invasive and Non-Invasive Cardiology and Consultant Cardiologist, PD Hinduja Hospital. Dr. Pandey brings extensive experience in managing complex cardiovascular conditions with deep expertise in cardiac electrophysiology and critical care. Welcome to the session, Dr. Pandey.
Thank you.
So, sir, to begin with, we will start with a very basic question that what exactly is potassium and why is it important for the human body?
I think most of us as doctors and clinicians have been taught quite extensively in our undergraduate days and later as well that potassium is the body's predominant cation residing intracellularly, meaning that our almost 98 to 99% of total sodium content of the body resides inside the cell in the intracellular compartment. And the balance between the intracellular and the extracellular compartment is very, very tightly regulated by renal function, aldosterone levels, and even cortisol levels for that matter. So I think this is very important to understand that this is an intracellular cation maintaining transmembrane potentials across the cellular membrane.
Correct. So I think when once we dive deeper into this session going ahead, we will hear more about its relevance and how is it important for the human body. So taking that forward, my next question to you is that where do we commonly get potassium from in our daily diet?
Daily diet, there are a lot of items. If you take any dietitian's potassium restricted diet chart, you will come to know that potassium is quite abundant in many dietary sources, such as fruits, like for example, bananas, oranges, and avocado, which is a fashionable fruit today. Vegetables, all green leafy vegetables, including spinach, potatoes, legumes, including lentils, like commonest dish which is made here nowadays in Mumbai is rajma, uh, and many other, including green peas, contain lot of potassium. And this standard Indian diet, as we know, is a predominantly vegetarian diet. Having said that, therefore, the mixed kind of Indian diet provides approximately 2.5 grams of potassium, whereas a predominantly vegetarian diet can give you as much as 4 grams of potassium in a day. And that, in absence of a normal renal function to handle for a human body, becomes difficult and challenging.
Correct. I think that gives an overview that where we could get the potassium content from to maybe have a right functioning of our body. So, having said that, why is potassium considered one of the most critical electrolyte to monitor in routine clinical practice?
All right. The normal level of serum potassium, which is extracellular, of course, is somewhere between 3.5 to 5 milliequivalents per liter. So you can understand the normal range is pretty narrow, and any potassium level of 5.1 to 5.9 is labeled as mild hyperkalemia, 6 to 6.4 moderate, and 6.5 or above severe hyperkalemia. And it is this level, moderate and severe, that is anything above 6 milliequivalents per liter, really is of serious concern to clinicians and particularly us as cardiologists, because one must understand that this is a cation which is indispensable for maintaining the resting transmembrane potential of neurological cells and cardiac myocytes. And therefore, this cation is responsible to maintain normal signal transmission in postsynaptic nerve endings, and of course, the smooth muscle contraction of the cardiac myocyte. Skeletal muscle contraction, yes, it is important as well there. And you must have heard hypokalemic periodic paralysis, and extremely rarely ascending paralysis that happens in patients with severe hyperkalemia. So this is a very important thing to understand about all of us, that this small, infinitesimally small cation regulates the skeletal muscle function, cardiac myocyte function, and postsynaptic neurotransmission in an extremely efficient manner for us to function normally. And levels more than 6 can unfortunately produce fatal consequences without producing any symptoms whatsoever to the patient. That is, I think, most important to understand. Hyperkalemia really, most often than not, does not produce any significant symptoms. And therefore, it is very important that we must monitor this molecule in select individuals who have a propensity or tendency to develop hyperkalemia.
Correct. I think that lays off the foundation of our discussion today. And with that, just to understand in a more detailed way, I'll take the next question, which is what is hypokalemia and at what threshold should it become a clinical concern?
All right. Though we label any potassium level of 5.1 milliequivalents per liter or above as hyperkalemia, uh, and any level 6 and above is of a serious concern to all of us, particularly cardiologists, one must understand it is equally important to keep in mind that the rate of rise of serum potassium is perhaps equally or more important than an absolute number of serum potassium. For example, Patients with chronic kidney disease who are not on maintenance hemodialysis, let us say creatinine of 2.3, 3, 3.5, 4, who are being conserved. They are on maintenance medical therapy, not on dialysis. These patients, invariably, their potassium level slowly and steadily creeps up over a period of decade from normal level to 5.6, 5.7, sometimes even 5.8. And they live perfectly normally with that level. However, a person with acute kidney injury whose potassium suddenly jumps from 4 to 5.5 in less than 48 hours can literally land up in cardiac arrhythmias and even cardiac arrest with that rapid rise of potassium. So I think the value is very important, definitely, but the rate of rise also must be kept in mind when you are attending a patient with hyperkalemia.
Yeah, I think that is a very well highlighted point from this discussion. And with that, I would like to ask that what are the most common reasons that potassium level rises in the body?
All right. So here, I think we as clinicians know for certain, as I said in the first, at the outset, that potassium is an intracellular cation, right? So there are three different mechanisms by which potassium can rise, because potassium is predominantly excreted in the kidneys. Why the kidneys? Any reduced renal excretion, either chronic kidney disease, acute kidney injury, or adrenal insufficiency, all of these can raise the potassium levels. The second commonest mechanism is the shift of intracellular potassium to the extracellular compartment. And this happens with any metabolic acidosis. The classic example is diabetic ketoacidosis, acute insulin deficiency syndromes, chronic beta blocker use, or whenever there is a massive cell lysis. And that is the classic example of that is rhabdomyolysis because of as a side effect of, let us say, statins, or acute severe myositis with breakdown of skeletal muscle cells, or tumor lysis syndrome where tumor cells are broken down by effective chemotherapies. So there a lot of extracellular potassium will rise because the intracellular potassium enters the extracellular space. And third, of course, is because of either dietary excess, blood transfusions, or potassium sparing diuretics like aldactone, ethylreninone, and finerenone, the non-steroidal mineralocorticoid receptor antagonist, and all RAS blockers. All RAS blockers, they ultimately can have potential of raising serum potassium. So three ways again. One, reduced excretion by the kidneys. Two, shift from intracellular to extracellular compartment. And three, excessive dietary excess or medications which increase potassium.
Correct. So, having said that, what distinguishes acute hyperkalemia from a more gradual or chronic elevation?
Yeah, I already said that if the rise in serum potassium from 4.5 to 5.6 happens over a period of 2 years, like in chronic kidney disease, then the myocytes adapt through the changes in transmembrane protein expression. But in acute hyperkalemia, there is no time. They have no time to do that. And therefore, if the potassium rises from 4.5 to 5.8 in, let us say, 48 hours because of acute kidney injury or rhabdomyolysis or tumor lysis syndrome, then, or diabetic ketoacidosis, then that potassium is very difficult to be handled by human cell membrane, and a very fatal cardiac arrhythmias can occur with that kind of acute rise of potassium. So the rate of rise of potassium is equally important as the value of a serum potassium level.
Okay, so why is acute hyperkalemia considered as a medical emergency? I think you already mentioned it previously, but if you could just highlight that in
Yeah,
this segment, that why is
yeah.
it considered as a medical emergency?
Emergency. That's correct. See, acute hyperkalemia is a medical emergency for three very, very important reasons. Number one, it is invariably, almost always asymptomatic. Patients don't have much symptoms of hyperkalemia. Some patients may complain of a little bit of fatigue here and there, but they are not specific symptoms. They are all non-specific symptoms. See, so some of them may directly land up in ventricular tachycardia or ventricular fibrillation as a consequence of acute hyperkalemia, because the acute hyperkalemia causes decrease in the ventricular fibrillation threshold by reducing the cardiac resting membrane potential. So we all know that the ECG signs of hyperkalemia, like tall T waves, then there is a PR interval prolongation, then the P waves become flat, called sino-ventricular conduction, and then there is a sine wave pattern, like a broad, bizarre-looking QRS complexes, and finally ventricular fibrillation. And this all trajectory from tall T to ventricular fibrillation can occur within a span of few hours if the rate of rise of that serum potassium is extremely fast. And therefore, acute hyperkalemia is almost always a medical dire emergency.
Yeah, correct. So I think you already mentioned that it is usually very silent and therefore it is very dangerous. But if you can quickly highlight, so are there any warning signs or symptoms patients or clinicians should watch for, and why is it often described as silent but dangerous?
Silent because it doesn't produce any specific symptoms. But in CKD patients and in elderly patients with RAS blockers, two symptoms should raise your antennae towards hyperkalemia. One is peripheral paresthesias, and two, when they complain of exhaustion or muscle fatigue. These are the two symptoms in my clinical practice I have seen often when I see retrospectively my patients. Oh my God, this patient came in hyperkalemia in the ICU, and 1 week back he was in my opinion. He did really complain of severe, asthenia or muscle fatigue, and I didn't pay much attention. So these are the two symptoms you must watch for, and quickly measure serum potassium so that you can treat it effectively and bring it down very quickly. So the muscle weakness or muscle fatigue and paresthesias peripheral are the commonest signs that I have seen in my clinical practice. Though literature describes that typical ascending paralysis, I have not seen a single patient in my career so far. So let us not talk about it. But these two one must remember because they are quite common.
Correct. So, I mean, in a normal clinical practice, how do clinicians confirm and assess the severity of hyperkalemia?
All right. So this severity can be assessed by measuring serum potassium level, but one must know a caveat that the sample should not be hemolyzed sample. A hemolyzed sample can produce spurious hyperkalemia or pseudo hyperkalemia by raising the actual potassium level by almost 1 milliequivalents per liter, and that something can produce a lot of clinical dilemma. And therefore, a well collected, fresh, non-hemolyzed serum potassium sample via a large bore needle. Large bore means 20 gauge or more needle, 20 gauge or lesser needle will be required to measure an exact serum potassium value. The sample should reach the laboratory within half an hour of collection and run so that the potassium is measured. The second is a 12-lead ECG. All right, that's a must. You cannot escape that, because hyperkalemia with ECG changes is far more a medical emergency than hyperkalemia without ECG changes. You will see so many CKD patients roaming around with potassium values of 5.6, 5.8 without any ECG signs of the same, and they are pretty safe. So once we measure serum potassium, when we know it is not a hemolyzed sample, then we grade that hyperkalemia, as I told you, 5.1 to 5.9 approximately is mild, 6 to 6.4 is moderate, and above 6.4 is considered severe hyperkalemia, life-threatening.
Correct. So, in case of suspected acute hyperkalemia, what is the immediate management priority?
All right, if you see a suspected acute hyperkalemia, it is acute, that is the patient's previous potassium level is not known. Then you look at the ECG first. If the ECG is showing 1 or 2 signs of hyperkalemia like tall T waves, prolongation of PR interval, then you can rest be assured that this needs immediate treatment. And what is the first priority? Our first priority, as I told you, to reset the cardiac transmembrane potential back to normal. That is the first priority. And how do I achieve that? By shifting the extracellular potassium in the intracellular compartment as a second step. But the first step is giving calcium gluconate. And this you can give, I think, in 10 ml of calcium gluconate, 10% solution over around 5 to 7 minutes. And you can repeat same dose in another 10 minutes if the ECG changes persist. The beautiful part of calcium is it immediately restores the transmembrane potential, irrespective of the fact that the potassium level per se will not go down, but the ECG changes will revert. You can see that immediately. And this we have seen that time and again in the casualty. And then the next step is then to bring or shift the extracellular potassium in the intracellular compartment. And that can be done by 2 or 3 different methods. One, if the patient is acidotic, give sodium bicarbonate. 2, if the patient is insulinopenic, give insulin, like diabetic ketoacidosis. 3, you can give patient insulin glucose infusion, that is 10 units of Actrapid in 50 ml of 50% dextrose. You can give slowly over a period of 30 to 45 minutes. I don't really like this to be given very fast because I have seen patients going in severe hypoglycemia with this regimen. So I give it very slowly, monitoring blood sugar every 15 minutes. And the third way of doing that is, as we know, the age-old nebulized salbutamol. But that in a cardiac patient, I really don't like, because it produces a lot of fast heartbeats, palpitations, and unusual sensation. And also, it is not a very efficient way to get down bring down the serum potassium compared to intravenous insulin or soda bicarb in an acidotic patient.
Correct. I think I was going to take that question as the next one, which was what steps are taken to temporarily shift potassium back into the cell. But I think you have very well covered it in the last segment itself. So we'll straight away jump to that. How is excess potassium ultimately eliminated from the body?
All right. So excessive potassium is removed via multiple routes. I mean, the major route is the renal route, that is via the kidney. The second route is the excretion in the stools, and that can be achieved by multiple drugs. And of course, these drugs were there with us before, but now we have better drugs available. So when you want the total body content of potassium to go low or go lower, then one can give loop diuretics like furosemide or even metolazone in the renal patient, because in renal patient furosemide alone may not work. So metolazone can be given provided there is at least some residual kidney function left. So this is, I'm talking about GFR between 15 to 45 or something like that. The second is the GI binders. I'm sure all of us remember and still are using calcium polystyrene sulfonate. The problem of this drug is it is not well tolerated by the patients. It acts pretty slowly, and after giving it for, suppose God forbid you have to give it again and again and again, there is that rare but serious complication of colonic perforation. So this is now superseded by 2 more molecules, and one is patiromer, which is still not available in India, and second is the sodium zirconium cyclosilicate, and I have used it in almost more than 100 patients so far. And beauty of that, it is tolerated very, very well, number one. Number 2, it brings down the potassium by almost 1 milliequivalence in almost less than 4 hours. So your job is done, I mean, you take the patient out of that medical emergency in something called semi-urgency, right? And then you get a lot of time to bring down that residual potassium back to normal by multiple other methods that we discussed earlier. So I think these are the ways in which we can bring down the sodium, ultimately reducing the total sodium content of the body.
Correct. Now that we have covered and understood that how what are the signs and symptoms and how can we manage these conditions, I would like to understand that what monitoring is required during and after acute hypokalemia treatment.
See, during the acute hyperkalemia treatment, three things are to be monitored very, very effectively. Number one, the acid-base balance. That you have to make sure that the patient is not acidotic at the outset and not becoming acidotic during your course of treatment of hyperkalemia. Because if the patient becomes acidotic, your hyperkalemia will return back again. That is number one. Second, you must make it sure that the patient is not becoming hypoglycemic with your glucose insulin infusion. Third, once the ECG becomes normal, I normally in my clinical practice keep on repeating the ECG every 2 hours till the potassium touches below 4.5 milliequivalents per liter. This is a very safe way to double check the lab. That means if you have spurious hyperkalemia, there will be no ECG changes. Remember that. Spurious hyperkalemia, there will be no ECG changes of hyperkalemia, right? Spurious is spurious, false hyperkalemia or pseudo hyperkalemia. And also, in the many times in busy labs like tertiary care hospitals like my hospital, Hinduja also, the turnaround time for a serum potassium sample from the collection till I get the report is almost 1.5 to 2 hours. So in that time, if my ECG is normal, I can be relaxed. But the ECG showed tall T waves. I need not even wait for the potassium to come back. I start treating that potassium level. So glucose monitoring, acid-base monitoring, and ECG monitoring are the three most important fundamental principles of managing hyperkalemia and monitoring the patient with hyperkalemia till he becomes normocalemic. Also, in patients with adrenal insufficiency, it is very, very important, in fact, to monitor the aldosterone levels and also the sugar levels very, very frequently.
Correct. I think with that, we come to an end of today's episode. And before summarizing this, I would like to take one piece of advice for our listeners of this episode before we wind up the session from you.
Yeah. So one simple piece of advice is hyperkalemia is far more rampant than what you clinically think. Number two, acute hyperkalemia is a life-threatening medical emergency. Please treat it as it is. Number three, when treating the hyperkalemia, look at the ECG all the time. A hyperkalemia with ECG changes is far more dangerous than hyperkalemia without ECG changes. Rate of rise of serum potassium is equally important as an isolated potassium value. And when you're treating hyperkalemia, monitor sugars, monitor ECG, and in select individuals, of course, you have to monitor their acid-base balance. Thank you.
Thank you for joining us on Potassium Matters, Decoding Hyperkalemia. We hope this discussion has helped you clarify key concepts and provided practically, clinically relevant insight that you can apply in your day-to-day practice for personal health awareness. Stay tuned for more episodes as we explore important topics, sharing and shaping clinical practice and patient care. Until next time, stay informed, stay vigilant, and continue to prioritize better health outcomes.